Hello everyone, and welcome to another case, this time demonstrating the use of cholangioscopy and electrohydraulic lithotripsy for the management of a large common bile duct stone. The patient is an 83-year-old woman with diet-controlled diabetes. About 18 years ago, she had a laparotomy for complex gallstone disease with associated gallstone ileus. She remained well after this operation until about 6 weeks ago, when she developed nausea, vomiting and itching. There was no abdominal pain or jaundice. The liver biochemistry was deranged, with a raised alkaline phosphatase of 163. An ultrasound scan at another hospital showed a dilated common bile duct at 15 mm and dilated intrahepatic ducts. The patient's general practitioner referred her to our gastroenterology clinic, and after review, an MRCP was performed a week ago. The MRCP showed a 25 mm cuboidal stone occluding the mid-common bile duct with several smaller stones below it. The patient now attends for an ERCP and cholangioscopy. The procedure is being done under conscious sedation using midazolam and fentanyl. As you can see, the papilla looks normal. Biliary cannulation was fairly straightforward. The initial cholangiogram shows the large mid-bile duct stone and several smaller stones below it. A biliary sphincterotomy is performed. My plan is to remove the smaller stones with a balloon catheter and then tackle the large stone with a cholangioscope and electrohydraulic lithotripsy. I use a 12 mm extraction balloon and sequentially trawl the lower common bile duct, removing soft stones with each sweep. I continue sweeping with the balloon catheter until the lower common bile duct is clear. I now introduce a Boston Scientific Spyscope into the bile duct over the guide wire. Once the cholangioscope is securely in the duct, the guide wire is removed so that the cholangioscope can be steered freely. The large stone in the common bile duct can be clearly seen, occluding the duct, and it is not possible to pass the cholangioscope past the stone. The next step is to fragment the stone using electrohydraulic lithotripsy. We used an autolith lithotripsy machine set at medium power with delivery of 30 pulses per press of the pedal. The EHL probe is passed down the channel of the cholangioscope and placed near the surface of the stone. With each press of the pedal, the resulting shock waves break up the stone. Sometimes the views become cloudy as a result of floating particles of stone. Suction can be applied via one of the channels of the cholangioscope, and the saline can be exchanged to improve the views. Eventually, the stone is broken up into manageable fragments and the cholangioscope is removed. Next, the stone fragments are extracted with a spherical balloon. We use a 12 to 15 mm balloon to troll the bile ducts. With each sweep of the duct, some stone fragments are extracted. We continue to repeatedly sweep the ducts until no large pieces of stone emerge. Next, the bile ducts are inspected, again with the cholangioscope. In the upper common bile duct, there are fragments of stones which have escaped the sweep of the 15 mm balloon. Since the upper bile duct is about 20 mm in diameter, we now sweep the duct with a 15 to 18 mm balloon inflated to its maximum diameter. Using this large balloon, the last remaining fragments of stones are extracted. A final check with the cholangioscope shows clear bile ducts with no large stone fragments remaining. The tiny fragments that can be seen should pass out spontaneously via the sphincterotomy. The patient remained well post-procedure. She had prophylactic diclofenac per rectum at the end of the procedure and intravenous Hartmann solution post-procedure. She went home after 4 hours of observation. I hope you enjoyed this presentation. See you in the next one. Bye for now.